Alright, welcome back. In this video we're going to finish up our discussion of the heart. We've been looking at some of the anatomy of the heart and the great vessels and the layers of the heart, and I want to move on to talk now about the electrical coordinating system of the heart, which is called the heart conduction system. As you know, both all types of muscles, skeletal muscle, cardiac muscle, and smooth muscle are contractile, and they're stimulated to contract by electrical activity, just like we talked about previously when we're talking about skeletal muscle. But the heart has a special conduction system that ensures proper contraction timing, because you must have a sequence of events where the atria contract and then the ventricles, and then they go back and forth. Atria contract, ventricles contract, atria contract, ventricles contract. And so you have a special set of cells that make up the conduction system that begins here at the sinoatrial node in the posterior right atrium. And the sinoatrial node has special cells which are autorhythmic, and so they spontaneously depolarize and fire action potentials. And these are special cardiac muscle cells that, although they have action potentials, they do not contract. So they are just conveying electrical activity. So again, electrical activity in your heart begins in the sinoatrial node. That electrical activity, those action potentials, then travel through the muscle of all of the atria, because those cardiac muscle cells in the atria are connected to one another through those intercalated discs, through the gap junctions. And then that is going to cause your atria to contract. The electrical activity then comes to the atrioventricular node, and the atrioventricular node functions to delay the electrical signal so that it pauses for a moment before going into the ventricles. It then enters into the ventricles through the atrioventricular bundle, which then branches out into these Purkinje fibers. And then the Purkinje fibers convey that electrical activity to the cardiac muscle of the ventricles, and then the ventricles contract. So that's an overview of the electrical conduction system. The rate of contraction is set by the sinoatrial node. It does not need to be started by your brain or any other nervous system structure. Just the cells in the sinoatrial node themselves are sufficient to set the heartbeat. However, you do have an influence by your nervous system over your heart rate, and also the contraction force of your heart. And that influence is provided by the autonomic nervous system. So you have a cardioinhibitory and cardioacceleratory center in the medulla oblongata, and they send parasympathetic and sympathetic innervation to the heart. The parasympathetic innervation is traveling via the vagus nerve, cranial nerve 10, and it functions to lower the heart rate. And you can see that it's doing that. Here's the vagus nerve. By interacting with the SA node here, and also the AV node. And so the parasympathetic nervous system can turn down the heart rate by turning down the nodal activity. The sympathetic nervous system is coming out of this cardiac nerve here on both sides. And it's also contacting your SA node and your AV node, but then it's also going to the myocardium, the muscle tissue of the ventricles. And so the sympathetic nervous system is going to increase your heart rate by influencing the nodes, and it's going to increase the contractile force of the muscle cells themselves. And so to summarize that, the medulla connects via the vagus nerve to your SA and AV node, and that's parasympathetic innervation. that decreases your heart rate. On the sympathetic side, we have the cardiac nerve, which goes to the SA node, AV node, and the myocardium, and as a result can increase heart rate and contractile force. You have a number of receptors, which I think we'll talk about more in the next chapter. Baroreceptors for stretch or pressure, and chemoreceptors, which can detect things like dissolved CO2 or pH levels that are able to pick up signals from various parts of your circulatory system, the aortic arch, for example, and then convey that to the medulla oblongata to either increase sympathetic activity or to increase parasympathetic activity. Okay, so we're going to go into a little more detail about the conduction system. Like I said in the overview, what happens first is that electrical activity begins in your SA node, sinoatrial node. It travels through the cardiac muscle of the atria, and that causes contraction of the atria. That electrical signal is delayed at your atrioventricular node because at that node you have a small number of gap junctions and also small diameter. That introduces a delay between the atria and the ventricles. The electrical activity then travels through the AV bundle, then into the Purkinje fibers, and finally through the cardiac muscle of the ventricles, which causes the ventricles to then contract. And here you can see that is summarized. The action potential begins here in these nodal cells, which make up the SA node, travel through the muscle of the atria. Then they're delayed at the AV node. Then they travel through the AV bundle, finally the Purkinje fibers, and the cardiac muscle cells. The actual contraction of the cardiac muscle cells is very similar to what we saw in skeletal muscle. The action potential is moving along the sarcolemma of your cardiac muscle cells, travels down into the T-tubule, causes the release of calcium. Calcium binds to troponin. Tropomyosin moves out the way. Myosin can then bind to actin, and in a power stroke will pull the thin fibers towards the center of the sarcomere. So unfortunately, we have two different action potentials that we need to keep track of. And let me just put that up here just to be clear. And this can be confusing because you may get lost and think we're talking about one thing when we're talking about another. So, everything keeps opening. In terms of the electrical activity, we're going to be looking at two different things. One is the activity at your nodal cells, your AV node, SA node, or your AV node. And then we'll look at electrical activity and the muscle cells themselves. You know, when we talked about skeletal muscle, we looked at electrical activity in neurons, in a motor neuron, which would be like number one, and then number two, we looked at the electrical activity in the skeletal muscle. The difference here is that the electrical activity is started by nodal cells which rest in the heart itself. And so the nodal cells have a resting membrane potential of negative 60 millivolts. They have a high concentration of calcium on the outside and sodium on the outside, and potassium on the inside. One very unique thing about these cells is that they spontaneously depolarize, and then another unique thing is that they have a calcium action potential. The fact that they spontaneously depolarize, you can also say they're autorhythmic, and you can take nodal cells and put them in a dish, like a petri dish, and grow a culture, and the cells will still depolarize with no outside influence. Okay, so you can see that the cell is going to fire an action potential over and over and over, and we're going to start here, number one, at reaching threshold. So what happens to reach threshold is that you have voltage-gated sodium channels opening up. And these voltage-gated sodium channels are funny. They're triggered by a negative membrane potential. I'll come back to that idea in a second. So sodium is going to come into your cell. That's going to cause your cell to become more and more positive. And once you reach the threshold value of -40, that's going to open up another set of voltage-gated channels, your voltage-gated calcium channels. And it also triggers the opening of your voltage-gated potassium channels. At that point, calcium will enter into your nodal cell rapidly, and that makes the depolarization phase of this action potential. Then the voltage-gated potassium channels open up, and that's repolarization. So you can see now that my voltage-gated potassium channels are open, my cell is going to become negative. Well, I said at the beginning that my voltage-gated sodium channels are triggered to open by this negative membrane potential. So here potassium is still leaving, and now my voltage-gated sodium channels are open. And they're open because of that negative membrane potential. And so because of that, this is going to occur in a cyclical way over and over and over, going from resting membrane potential to positive and all the way back. So that's happening in our SA node, and that activity is spreading following the pattern we previously talked about through the atrial muscle to the AV node, AV bundle, Purkinje fibers, and then the ventricles. If the SA node becomes impaired, the atrioventricular node can take over. The atrioventricular node has a much slower inherent rhythm of 40 to 50 beats per minute, but is fast enough to sustain life. If you damage both the SA node and the AV node, well, cardiac muscle also is autorhythmic, but it only beats by itself at 20 to 40 beats per minute, and that's too slow to keep you alive. Okay, so we just saw the nodal cell. It has, it's autorhythmic. You have voltage-gated sodium channels that open spontaneously, bringing the cell to threshold. Then you have voltage-gated calcium channels open, followed by voltage-gated potassium. So now we'll look at the cardiac muscle cell, and they're going to be stimulated to contract by the activity from the nodal cells. We have 3 different channels to keep track of here: the fast voltage-gated sodium channel, slow voltage-gated calcium channel, and a voltage-gated potassium channel. And we have the same arrangement of ions where sodium and calcium are high on the outside and potassium is high on the inside. Okay, to start out with, and again, we're talking about cardiac muscle cells. Depolarization occurs when the cardiac muscle cell, is influenced by an action potential from the conduction system, either from the nodal cells or from other cardiac muscle cells that were themselves stimulated by the nodal cells, because they are all connected to one another in the atria via their gap junctions. As well, they are all connected to each other in the ventricles via their gap junctions. In any case, you receive an action potential from the conduction system. This opens up voltage-gated sodium channels. That causes the depolarization phase. It also triggers the opening of your other voltage-gated channels, but they are slow. So up here you have this slow voltage-gated calcium channel becoming open, as well this voltage-gated potassium channel becoming open. And so what's happening in this phase called the plateau is that simultaneously you have potassium leaving your cell, making it, which would make it more negative, and calcium entering your cell, which would make it more positive. So right here during this plateau, you don't have a huge change in your membrane potential and the voltage because you have both potassium leaving and calcium entering. And so you stay at around the same membrane potential. And the reason that plateau is important is that it prevents irregular heartbeat and tetany. And we'll see that a little bit more later. But this whole cycle has to complete before the heart cell can be stimulated to contract again. That's unlike skeletal muscle, which you can stimulate to contract, over and over and over in a small period of time. This whole cycle has to finish, and that plateau makes the cycle take longer to finish, and that prevents, again, tetany, which would be the seizing up of your heart, and irregular heartbeat. And repolarization is accomplished, as it usually is, by potassium leaving through the voltage-gated potassium channels. And at this point, the voltage-gated calcium channels are closed. Okay, so some similarities is that they both start out with both the nodal cells and the skeletal muscle cell start out with voltage-gated sodium channels, followed by voltage-gated calcium channels, followed by voltage-gated potassium channels. The big difference is that the nodal cells' voltage-gated sodium channels open due to a negative membrane potential, and the cardiac muscle cells have this plateau. So like I said, unlike skeletal muscle, cardiac muscles have a long refractory period, and you cannot make a cell fire another action potential during the refractory period. So that plateau phase gives the cardiac muscle cell a long refractory period, which is about 250 milliseconds long, and this ensures that the heart cell is going to contract and relax before it can be stimulated again. So this image, these two images up at the top are showing you skeletal muscle cells, and we'll contrast that with cardiac muscle cells down here, talking about tetany and how that plateau phase prevents it. So in a skeletal muscle, you have the action potential, which is the electrical activity that precedes the muscle contraction. And then shortly after that, you have the muscle contraction. If you put more frequent stimulation, so you drive more action potentials, the muscle will contract until it's totally seized up, until you have used up all of your ATP and you reach a fatigue state. And that's because the electrical activity of your skeletal muscle has a very short refractory period. So once that refractory period is over, you can fire another action potential and trigger another muscle contraction. So as they've done on the right side, those muscle contractions add up so that the muscle is contracting without having fully relaxed. So this is the muscle contraction. It hasn't relaxed, another contraction starts, another contraction, another. And those contractions are happening on top of each other, leading the muscle to, seize up. So you're just contracting and continuously. In contrast, the cardiac muscle cells have a long refractory period. So just like in skeletal muscle, you cannot fire another action potential during the refractory period. And that's just a very, very long refractory period because of that plateau phase where you have calcium coming in at the same time that you have potassium going out. And so if you put more frequent stimuli, it's not going, if you put like a electrode onto the cardiac muscle cells, you're not going to be able to drive them to fire more frequent action potentials. So even if I stimulate over and over and over, I'm still not going to be able to make that cell fire action potentials until that refractory period has passed. And so that plateau phase makes tetany impossible, and your cardiac muscle cell which keeps your heart from locking up. You can take a look at the electrical activity of your heart through an ECG recording, which you would record using skin electrodes. You detect the electrical signals of your cardiac muscle cells, and this is a composite signal, meaning that you're just recording from a ton of cardiac muscle cells at the same time. And this is illustrating a typical ECG recording over here. Sometimes the activity in these composite traces looks weird. Also depends on whether electrical activity is moving towards or away from your electrode. So you're not always going to see it having the same kind of shape as an action potential, even though it is showing you a bunch of action potentials happening in your cardiac tissue. Anyway, this first wave here, the P wave, is showing it is reflects atrial depolarization. Then the QRS complex reflects ventricular depolarization. During that same time, during the QRS complex, the atria are also repolarizing. They're having potassium leave from their cells. But you can't see it on this graph because the electrical activity of your ventricles is just so much greater, and that swamps out anything that's happening in the atria. And then finally, in the T wave, you have ventricular repolarization. And I hope that makes sense as a sequence of events, because when your heart is contracting, your atria contract, that shoots blood into your ventricles. Then your atria relax, your ventricles contract. Then your ventricles need to relax. And so you have atrial depolarization, atrial repolarization, though you cannot see it, ventricular depolarization, ventricular repolarization, reflecting the activity that needs to happen to pump blood from your atria to your ventricles, then from your ventricles out. An arrhythmia is any deviation from the heart's normal electrical activity, and a very dramatic and common one is ventricular fibrillation, and that occurs when you have uncoordinated or chaotic electrical activity in your ventricles. So the SA node is no longer in charge, is no longer running the whole show. And unless your muscle is coordinated, unless you have the atria coordinated, contract, then relax, then the ventricles contract, then relax. If they are just kind of spasming around in random ways, the blood is not going to go anywhere. And so that ventricular fibrillation can be triggered by a heart attack. And here's, what it might look like on an ECG. And if somebody has gone into ventricular fibrillation, you would treat that with one of these automated external defibrillators, which will interrupt. It's sort of like kicking your computer. So it will interrupt that electrical signal, allowing the SA node a chance to reset and reestablish the appropriate rhythm. Okay, we'll talk about now the cardiac cycle, and this has always seemed sort of unnecessarily complicated to me, but we'll go through it, and I guess keep in mind as we go through the details that what's happening is that the atria contract, then relax, then the ventricles contract, and then relax, and that's the essential overview of what's happening here. Okay, so the electrical activity begins in your SA node and then travels into your atrial muscle. That begins your atrial contraction. The atria are contracting, causing any blood that was previously remaining in the atria to travel into your ventricles. You could measure then the end diastolic volume. Diastole is a relaxation and systole is the contraction. So the end diastolic volume would be when the ventricles hold their maximum amount of blood. It's the end of their relaxation phase, so they are receiving as much blood as possible at that point from your atria. During this atrial contraction and ventricular filling phase, the opening of your great veins is compressed, and so no blood is coming into your atria. Moving on to isovolumetric contraction. Iso means the same, volume means volume. So in isovolumetric contraction, you have the beginnings of the contraction, but the volume of the heart does not change. So here, the ventricles are stimulated to contract by your Purkinje fibers, and then the muscles begin to contract, but the volume doesn't change yet, and there's no change in volume because the pressure in the ventricles has not yet overcome the arterial pressure. So, the ventricles need to contract hard enough to open up these semilunar valves and shoot blood into the aorta and pulmonary trunk. And while the ventricle pressure is high, this is also pushing the AV valves closed, so that blood does not go from the ventricles into the atria. Okay, the next phase, ventricular ejection, is when the contraction has proceeded enough that the pressure in the ventricles is greater than the pressure in the arteries, so that you open up the pulmonary and aortic semilunar valves, and then blood goes into those arterial trunks. So you could look at here the stroke volume. They're illustrating the volume of blood here in the aorta, which is the amount of blood pumped during ventricular contraction, which is about 70 mLs. After the ventricles contract, there's going to be some blood left over in the ventricles, and this is the end systolic volume, the blood left over after the ventricular contraction. Finally, we have isovolumetric relaxation. The ventricles are relaxing, the atria fill with blood, and the semilunar valves are closed because now there's not pressure in the ventricles, but there is some pressure in the arteries that is pushing back on the semilunar valves, causing them to close. Finally, in the last phase, atrial relaxation and ventricular filling, the AV valves open. You have a little bit of pressure from the blood inside of the atria that opens up the AV valves, and blood is going to move then from the atria into the ventricles. Then we'll go back to the beginning, where any remaining blood in the atria are going to be ejected when the atria contract. Okay, one thing that you can look at to measure the effectiveness of the cardiovascular system is cardiac output. And cardiac output is the amount of blood pumped by one ventricle in 1 minute. And that should be the same for the left ventricle and the right ventricle, because the ventricles pump equal amounts of blood. If they don't, then you're going to end up with edema or swelling in your systemic tissues, or pulmonary edema and swelling in your fluid and swelling in your lungs. So you can calculate cardiac output with the following formula, which hopefully makes a lot of sense. The amount of blood pumped by the ventricle depends on the heart rate and the stroke volume. So the heart rate is measured in beats per minute, and the stroke volume is milliliters ejected per beat. So if the heart contracts, harder, it's going to eject more. Or if the heart is allowed to fill up with more blood, it's going to eject more blood, and that's going to change your stroke volume. Anything, particularly drugs, but anything that affects the heart rate will be called a chronotropic agent. So some positive chronotropic agents would include sympathetic stimulation, thyroid hormone, epinephrine, norepinephrine, as well as a variety of drugs like caffeine, cocaine, etc., etc. Negative chronotropic agents include parasympathetic stimulation and beta blockers, which is a pharmaceutical. Stroke volume, anything that affects that. Oh, let me go back to heart rate for a second. So chronos, or chrono means time, and so chronotropic is affecting the timing or the heart rate. Inotropic agents affect the stroke volume, and so one way you can change your stroke volume is by exercising. When you exercise, that increases your venous return, because as we'll talk about, one of the primary things that moves blood through your veins is contraction of the surrounding skeletal muscle. So if you fill up your heart with more blood, you're going to eject more blood. Positive inotropic agents include sympathetic stimulation, because we saw the sympathetic fibers go to the myocardium, not just to the nodal cells, and also thyroid hormone. Negative inotropic agents include beta blockers and benzodiazepines, and there are many others for both groups. I just am giving you here some examples. So that's it for the cardiovascular system for this chapter on the heart, and the next chapter we'll talk more about blood vessels.